Hello, everyone, and welcome to our webinar on homelessness, mental health, and prevention. My name's Dania. I'm the Policy and Communications Lead at the Association of Mental Health Providers. The association is a representative body for voluntary and community sector mental health service providers, from locally focused to regional and national organizations working across all types of service and provision. We're hosting this webinar, the last in a series of 6 now, as part of a wider project on the Prevention Concordat for Better Mental Health, which we have been commissioned to lead by the Voluntary and Community Sector Health and Wellbeing Alliance. The project looks at the role of the VCSE in preventing and improving outcomes for people with mental health conditions. All the webinars that we're doing are based on briefing papers, which are due to be published in the summer, and aim to create a better understanding of the current prevention landscape in relation to particular groups of people who experience disadvantage and face health inequalities. Both the webinars and the briefing papers are highlighting the issues that are encountered, whilst also outlining the role of the VCSE in the prevention of mental ill health. So through these, we hope to create an understanding of how statutory services and commissioners can work with the sector to reduce health inequalities to prevent mental ill health. The Health and Wellbeing Alliance is a partnership program which is managed by the Department of Health and Social Care, Public Health England, and NHS England, and is made up of 21 organisations and consortiums that represent communities who share protected characteristics or that experience health inequalities. Today's webinar is being delivered by Caroline Bernard and Leroy McAnuff from Homelessness Link, and they will present, and after that we will have a Q&A session, which will be open up to all the attendees. All the attendees at the moment are on mute, but there is a chat function and a questions tab on your control panel. So please do send in your questions while Caroline and Leroy are presenting. The presentation slides are available in PDF in the handouts tab on your control panel as well, but I will also now share my screen and hand over to Caroline. The webinar is also being recorded, so this will be made available after. So over to you, Caroline.
Morning everyone, and thank you for taking part in this webinar. We're really pleased to have so many of you here. So myself and Leroy McAnuff are here. We are from Homeless Link. I'm head of policy and communications, and Leroy is our Homeless Link expert panel member and also an NHS service user consultant. He has experience in mental health issues and homelessness, and can speak with confidence and understanding and knowledge, of course, personal experience of some of the issues. On to the next slide, please, in terms of the overview. So one more, please. Yes, we're going to be looking at the rough sleeping strategy, so the policy context and the long-term plan that we work to influence as part of the Health and Wellbeing Alliance. I'll talk about the relationship between mental health, housing and homelessness. There's a very key relationship and links there that it's important to be aware of. And then Leroy will take over and talk about his experience of the whole issue that we're talking about, and he'll share his story with you and talk about some of the things that we need to think about in terms of relationship between mental health, housing and homelessness. I'll then look at the barriers to the prevention of mental ill health as related to homelessness. And then I'll look at some ways in which the voluntary sector can work towards addressing homelessness and mental health issues, and what we can bring to that conversation and what solutions we can provide. I'll share recommendations with you that we've made for our briefing that Dania mentioned earlier, that are being written as part of this project, and then hand over to you all for questions and discussions. At the moment, Leroy's having trouble with headphones and can't hear, he can hear me, but he cannot hear Dania at the moment, so hopefully we'll be able to swap over desks and he'll be able to use my headphones to listen. So bear with us during the technical issues, but we'll manage that quite well, I think. All right, on to the next slide, please. So the policy context. So Homeless Link have 750 members, and we have a wide stakeholder engagement group as well. We've long been calling for a cross-government approach to ending homelessness, including working with health partners. And being part of the Health and Wellbeing Alliance has been really key to us doing this, and we've been really excited to be part of that for the last couple of years in terms of what we'll be able to deliver through the Health and Wellbeing Alliance, including this project here. So government have really involved us in working together to come to find a new approach to ending rough sleeping. And we've highlighted homelessness itself as a health inequality, because homelessness in itself, rough sleeping or any kind of homelessness, is a health inequality in itself. And just to note, rough sleeping is obviously what people see on the street as being homelessness, but also there's temporary accommodation, there's hostel dwelling, sofa surfing and overcrowding. These are all forms of homelessness. So do bear in mind that homelessness is really about more than rough sleeping. So that's just kind of being clear on what homelessness actually means. And really the two go together. So homelessness and mental health do go together. And there's a bit about how policy and practice can be influenced through discussing those things. So on to the next slide, please, rough sleeping strategy. So this was published in August last year. We were very much involved in it because we were part of the task and finish groups that were going on in government. And we helped shape the strategy by having conversations with officials through that, through those task and finish groups. And what it aims to do is to halve rough sleeping by 2022 and end it by 2027. So a big ambition, especially in the current climate where we've got a new Prime Minister coming along and inevitably a reshuffle as well. We have a key challenge in actually making this happen. So I'll talk a bit more about the kind of the structural issues later, but that's the vision that the government have got. But within the strategy, there's also an ask for NHS England to spend £30 million pounds on health services for those sleeping rough over a 5-year period, and this is the plan that's set out in the strategy. And there was also an audit of health provision that was due to happen last year, but I think it's still going on, hasn't reported yet. So the audit of health provision, we're looking forward to seeing what will happen in that and what that brings to the landscape. So on to the next slide, please. This sets out the 3 key planks for the strategy. So the 3 themes are prevention, intervention, and recovery. So again, we were very keen to influence these 3 areas. So prevention for us is really about understanding what the issues are that lead to rough sleeping and providing some timely support for those people who are currently at risk. And on intervention, it's about helping those who are already sleeping rough or who are already in homeless situations and looking at rapid response and very quick support given that's tailored to their circumstances, because too often people come along to services, and because there's a silo working and because services are not geared up for that kind of flexible way of working for those who may have chaotic lives, the interventions are not always tailored. So we're very keen to kind of see through a strategy how that kind of tailored support will happen. And then finally, recovery, looking at people being supported in finding a new home and rebuilding their lives. So finding a new home is clearly one piece of it, but it's also the bit about people having that support around them to be able to maintain that home and rebuild their lives in that space. So those are the key planks of the rough sleeping strategy. On to the next slide, please, which is on the NHS long-term plan. So this, as you know, came out in January this year, and we were very pleased to see the influencing work that we've done have a health inequalities focus in the long-term plan, and it sets out a key plan for investment in the NHS over the next 5 years. So again, we were able to meet with officials in the long-term plan development. We talked to people like Neil Churchill, we met with Simon Stevens. We did a written submission as well. There's an inclusion health subgroup that is part of the Health and Wellbeing Alliance, and we did a written submission through that group to the NHS long-term plan. So we were really pleased to see the £30 million committed to ensure a better access for mental health services for those who are sleeping rough. And there's another goal also for nearly 300,000 people living on the streets to be, sorry, there's a typo there, with severe mental ill health, to have physical health needs met, and that's over the next couple of years. So again, really happy to see that goal in there. Actually, only this week there was a report in the news about people who are in mental health services having poor dental health. And not receiving treatment and having having serious dental health problems. So it's important that people who have physical health needs alongside mental health needs, have those needs met. And something as straightforward as dental care should be part of that. And it's worrying that people are not having those very simple needs met when they are in mental health services. So it's a bit about really making sure there's a holistic support given around physical health alongside mental health. So that's really important for us going forward. So on to the next slide, please. I'm going to talk about the relationship between mental health, housing and homelessness. And Leroy may want to chip in here. So Leroy, do give me a sign if you want to chip in, and I will hand over to you. So there's a big question here. Does mental health cause homelessness, or is homelessness cause of mental health? And for us, it's not really, there's no right or wrong answer, because these can be mutually reinforced issues. And we need to think about multiple disadvantage, and we need to think about mental and physical health issues together, because these things are often reinforced by substance misuse, by social exclusion, and by just generally multiple disadvantage. People who are experiencing mental ill health often fall into homelessness, and vice versa. So there's no right or wrong answer to this question. And Leroy is going to pop over and give you his thoughts on this right now.
Hello there. I'd like to say there is a correlation between the two. Having experienced both symptoms myself and experienced both elements, mental health can lead to homelessness, and the homelessness can in turn lead to mental health, because basically if you're not well in your mind, you basically do not really have the capacity to keep or to remain in a permanent state of housing. So basically you can get behind with your bills, you can get into a chaotic lifestyle because due to your mental health, and that can lead to you actually being homelessness. And when you're homelessness, your mental health state and capacity increases in terms of you being unwell, and obviously the stress that brings. So there is a direct correlation between the two, and obviously the key thing is to address both areas so that you don't have a chaotic and a dismal outcome for an individual. I believe that you need to have joined up thinking between mental health practitioners and housing practitioners in order for this to work, and the individual to take advantage of this, which hopefully will stop the reoccurring cycle between mental health and homelessness.
Okay, so thank you, Laura. That's exactly the situation we're looking at here. So, I think there's bits about sleeping rough in itself, and how it is a traumatic event in itself, and it can result in PTSD, other mental health issues. And the research that Mungos did 3 years ago talked about 4 in 10 people sleeping rough have a mental health illness. So you can see that there's a direct correlation, as Leroy said. The whole issue about debt that Leroy talked about is really key as well. And we're really keen in our work at Homeless Link to really highlight to government and to influencers that unless you address those structural issues that like welfare reform and all the issues around debt and that's going on right now, you're not going to address homelessness and things that relate to it, because people are getting into serious mental health problems because of not having enough money to live on. So it's really important to discuss that. So on to the next slide now, and Leroy will give his experience really in terms of what he sees as his own experience as someone who's used services.
Yes, hello again. As an individual who's had lived experience, as I said previously, there is a link between ill health and homelessness. I have found, even personally myself, and seen others follow the same routine, that you go into A&E simply for sheltering and to obviously have somewhere to rest your head during the times when you're in a homeless situation. When people are unwell or people have an episode, as we call it, they would go into A&E, and from A&E they would go into the acute ward, or and there would be a cycle where they'd go from the acute ward back to A&E, then from A&E back to the acute ward. And there needs to be a street community initiative, or there needs to be a joined up initiative, I should say, between the NHS services and the housing services and the A&E to actually track people, to make sure that there's not a never-ending cycle. The support in the community seems to be severely lacking, and this is a main cause of people returning to A&E. And obviously you have people that are self-referral, and the doctors or their GPs don't seem to be able to come into the equation, to obviously, when they get their letters through that this person has attended A&E, there not seem to be any sort of follow-up in terms of the why people are constantly going to A&E, coming out, going to acute wards and back again. There are well-being hubs in the community. I don't know, a lot of people don't seem to be aware of this, that can provide assessment and talking therapies for people that are in crisis, are in and other professional support. So that could be one way of stopping the constant toing and froing between A&E and acute wards and back and forth, which obviously doesn't help to a person's long-term recovery. However, these don't seem to be well known now. The message doesn't seem to be getting out there. And I think this is a key thing, that people can have a place to speak to someone and not necessarily have to go into a ward. But if, like, for instance, I know from personal experience, have you had an episode of you're feeling quite ill or low at a particular day or particular moment, you can speak to someone and they can decide, well, is talking therapy enough? Does this person need to go into a ward for further assessment, or the likely remedies or actions that need to be taken? So, but to break this cycle overall, I think there needs to be a coalition between service providers, i.e. A&E, the A&E acute wards, the acute that people go to, the housing community, the social services, so that people who are constantly will go to A&E and go to self-referral through that process. Well, what can we do? Can we visit them? Can we find out what personal problems there might be that we can address from a community's perspective to stop this happening? And I think that this would obviously in the long term help to stop the ongoing process of mental health and homelessness, which are obviously, are dual reasons why people can become chaotic in their lives.
Okay, so back to me. Now, thank you, Leroy, for that. That just shows you the kind of issues that we're dealing with here, and it's very complex. And I think there's a very key need for services to work together to come to solution. So on to our next slide, please. So on the barriers to preventing mental ill health, I think that there's there's challenge, because we've got high levels of registration in GPs by individuals, but many people who do not have an address are not receiving primary care access. They're being turned away when they're trying to register without an address to a GP or a dentist. and again having to go to A&E, as Leroy said, to patch up their symptoms or get themselves sorted and then back to the street again. We did a health needs audit a few years ago, and that found that 17% of people with mental health needs who were in that survey were not receiving any treatment at all. So you can see that there's a huge issue about primary care and how people can access mental health support when they need it. We do an annual review of single homelessness supports in England, and 2/3 of people, of clients actually that were in that survey, were using accommodation services, and they all had difficulties accessing mental health support. So there are some big challenges here. There's also discussions around waiting times as well. So there's waiting time, there's diagnosis in the first instance. So again, people who may have a mental health condition may not have a diagnosis for many years. They'll be living with that for many years, maybe from very early age, and not have had any diagnosis at all. And then when you do get a diagnosis, there's an issue about waiting times and actually getting treatment at all. Sometimes people can be in a service longer than it takes them to get the actual service. They may have actually moved on from that service before they get their mental health treatment and support. So there's some real issues here. And the other thing is about being excluded from treatment if your symptoms are not deemed to be severe enough, which might sound quite bizarre, but it's a bit about crisis care. Treatments are often only available when someone goes into crisis and ends up being sectioned, for example. So again, the whole discussion about prevention is really important, because unless we can address these barriers, you won't be able to prevent mental ill health from taking place. So there are some big issues around high thresholds. So on to the next slide, please. This talks about really the support that we can bring as a voluntary community social enterprise sector to prevention of mental ill health. We have a strong role in actually preventing mental ill health and promoting good mental health, and we're quite effective in engaging so-called, I don't like the term hard to reach, but the term is used, hard to reach communities, or those who are seldom heard. I prefer that term. And we also have a lot of evidence in our sector on the importance of safe, warm and secure housing and the impact of that on people's health and happiness. On another bit of work for the Alliance I did last year, we were involved in some work looking at homeless families along with the Association for Young People's Health. And the mothers I met at a focus group there talked about the temporary accommodation they were living in, which was often not clean, not warm, and they felt, fearful for their children's health and safety. And they talked about the low mood they experienced. They actually were experiencing low mood because they were living every day in this really poor environment. So there's direct impact on your mood and your happiness. And it might sound very obvious, but there's evidence that they're on that. But even though the evidence is there, we know it's common sense, people are not always able to access safe and secure housing. There's also a piece about how services can work with the voluntary sector. You can work in a kind of a flexible way, because our organisation is often quite flat and we can be quite nimble. So we can work with colleagues in mental health services very flexibly and work with supported housing and housing first models, because those models have been proven to do well for people who've got mental health issues and who are very entrenched in their rough sleeping and who've got very entrenched issues like drug and alcohol dependence and so forth. So we can work in that way. And housing first is one of the approaches that can work alongside supported housing I mentioned before, but also we can bring skills and knowledge in psychologically informed environments so that services can work in a psychologically informed way. There's very clear principles to that. We can work in trauma-informed ways with people, and again, support services in doing that, in housing and outside of housing as well. And we bring very strong peer support. Leroy is one example of somebody who provides peer support and also is a consultant to the NHS, but also we have people like Groundswell who are a member of Homeless Link who have a peer advocate advocate scheme that can work with individuals who experience homelessness and mental health in supporting their peers and helping them to, get through the challenges they're facing and to address them in an empowered way. So we bring those skills along to the sector and work with health in these ways and those approaches that can work for individuals. So on to the next slide, please. This is our last slide. This gives the recommendation that we've put up in our briefing to this project that sets out what we think could work and what we need to see in terms of improving prevention of mental health as related to homelessness. The first thing is about really being clear in creating partnerships between services. So CCGs and local authorities and using make it every adult matter approach, which is really an approach that involves people who have multiple disadvantage and complex needs in actually working with them and ensure that they have a say in the services they get using co-production. We think it's important to address the primary care issues I mentioned earlier, people with multiple needs across mental health and addiction and others as well. Investing to save is quite key, so putting money into prevention services and early intervention services can help more costly crisis interventions later down the line. Work with your specialist services, work with those who've got knowledge, who can target people who are homeless, who have multiple disadvantage, and using peers to do that. Promoting the use of PI, psychologically informed environments, and trauma-informed approaches is really important as well, and promoting those and actually embedding those in services are really important as well. Co-production, I mentioned earlier, the MIM approach, but also to ask people who use the services what they need, what would work for them, rather than assuming what they need and doing to them, do it with them. Be flexible, try and be nimble, so people who have lives that are not as straightforward as everybody else can engage, because if you have a chaotic life, appointment systems don't always work for you. You might not make your appointment, then you may get barred from services. So again, be flexible, understand people's lives are often not straightforward and can be complex. Think about work on housing solutions and how you can develop those with people so that you have integrated supports that work with people with mental health issues. And then training frontline health and housing workers in mental health practices, so that again there's cross-learning for individuals who are working on the front line. We have communities of practice that work across the country in homelessness that bring all kinds of different issues to the table, and one of them is always mental health. So that's all we had to say. So the last slide is really our question and discussion slide. So really keen to hear from colleagues what they'd like to ask us. I can't see anything in the chat. It could be just I've not clicked into it, but colleagues can tell me if there's anything in the chat that I need to be looking at.
Leroy, let's have a look. Okay, so we have one question at the moment. So please do send your questions in. We've got some time for a bit of discussion now. So Caroline, the question is that you mentioned that mental health and homelessness can be affected by substance misuse. However, NHS...
Hello, Dani, I can't actually hear you at the moment, so I don't know.
Okay, let's try that again. Can you hear me now? Sorry, everyone, for these technical issues today.
I can't. Just check. I can't hear.
I can hear you, Dania.
Hello?
Hello?
I can hear you now, yeah.
Okay.
Okay.
Right, so I was saying that there's one question at the moment. So
Okay.
it is, you mentioned that mental health and homelessness can be affected by substance misuse.
Yeah.
However, NHS in a lot of areas do not do dual diagnosis to act on both mental health and substance abuse at the same time.
Yeah.
Has dual diagnosis been raised as a good practice guide for the NHS in their new plan?
No, I had to look at the plan. I can't actually. I don't know if anyone on the call. I don't know if Felicity can talk about that. Is on the call. But I think from memory that there is mention of it in there. Well, I think what the issue with the plan is mental health is the main focus at the moment, and we have raised with NHS England that we need to think about the kind of wider issues as well, such as dual diagnosis. So actually, no, it's not in the plan. It's something that we've actually been talking about. It's something that needs to be looked at as things roll out. Homeless Inc is a member of the rough sleeping advisory group in the Department of Health and Social Care. So through that forum. We're talking about wider issues and what we can do there. Tom Johnson, who leads on mental health for the plan, comes to that group as well. And he and I have talked about some of the things as well that we need to be thinking about. But certainly the plan needs to look a bit more widely eventually than the mental health. But it's a good start, because there's a lot more to do.
Great. Felicity, who is from NHS England, everyone, is not actually connected to our audio at the moment, so can't jump in.
Okay.
But we'll move on to the next question in the meantime.
Okay.
So someone is saying that they agree with you that the term hard to reach is unhelpful. So in view of place-based approaches to public health, can you suggest how health can reach homeless people where they are? Is that best through the voluntary sector?
I think the voluntary sector probably can help on that, because we, our members rather than us, homeless members provide the services. We have members that can actually work with people on a regular basis. And I think what's important to do is that health partners should make links with their homelessness partners in their area. We have partnership managers in every region of the country, and they talk to our members in those regions. But you can use them or other mechanisms to reach your homelessness partners, to find people where they actually are. Now, of course, street homelessness is challenging, and outreach workers go out every night, sort of people through street and through other mechanisms as well. But I think there's something about working with your day centres, with your night shelters in the local areas, and just finding out what the issues are they're facing. And if you want to go along to the day centre, meet some people there, talk to them. That's one way I think of engaging that could really work well.
Thank you, Caroline. So just to mention that if anyone would prefer to be to speak to Caroline and Leroy and say the question, please raise your hand and we can unmute you. I know it can be sometimes a little bit difficult to have to type your question in, so do raise your hand if you would like to do that. So in the meantime, how do you think the new primary care networks will help to remove barriers for people who are homeless and have mental health needs at primary care?
My hope is that they'll work well. I think it's positive we've got this, and I think that the primary care networks should, in my view, provide a way of addressing some of the challenges people are having accessing primary care in the first instance, through things like, for example, training. I know there's not on the table, but training receptionists, for example, or training frontline staff in things like the Homeless Reduction Act, the duty to refer that comes from that act. And also just recognising the actual way the law works around people who don't have an address. If you approach primary care and don't have an address, we know that you can actually use your hostel or day centre for that. So it's about the primary care networks hopefully bringing that learning to the sector, to the primary care front line, to address some of the barriers that are currently in place. So that would be my wish for the networks.
This one I think is asking a bit more for your opinion and thoughts. Do you really feel that by 2027 that homelessness will be significantly reduced or totally eliminated?
Okay, yeah, this is very much me, and not, this is just me speaking.
Yes.
I think that we have to be optimistic, and we have to drive towards that goal, because if the government are committed to that goal, and hopefully with the new Prime Minister and ministers, that goal will be maintained, we can end it. I'll give you an example. In Finland, rough sleeping has been almost eliminated. They've managed to do that through a range of things. Primarily housing first has been the main thing they've done that's addressed it. So they've proved that it can be done. And also, before I was in the sector, I think around 2008-9, we had very low numbers of rough sleepers. So we know we've done it before, and I think we can do it again. We just need a kind of coordinated approach, cross-government approach that works with all the partners involved to make it happen. But ultimately, you also need affordable housing and more of that to actually access for people to have somewhere to live.
I will hand over to my colleague Kerry, who has a couple of questions.
Thanks, Tanya. My first question is, one of the things you talked about, Caroline, was the kind of in terms of prevention, was one of the things that was leading people towards homelessness was welfare rights issues, debt, poverty. Do you feel that cross-government wise, DWP are fully engaged with the rough sleepers agenda or with the strategy?
They are beginning to be. We are involved in a DWP stakeholder group that meet regularly, and we are asked to go along regularly to that and say what our views of our members are. So yes, they are beginning to be very engaged with that, and we talk to them a lot. So I think whilst these issues are still there, and it is policy, and at the moment we are where we are with universal credit and other issues around that, government in that department are beginning to listen, although I think the influencing has to happen over a period of time before things change. But yeah, they are listening to what our members have to say through us, so the change is beginning to start, but there's a long way to go.
Yeah, great, thank you. And I wanted to ask Leroy, so I know it might take a minute for him to come back.
Okay, I'll hand over to Leroy now. 1 second. Okay. Yeah, here's Leroy now. 1 moment.
Lovely, thank you.
Hello there.
Hi Leroy, I'm Carey. I wanted to ask you, if you don't mind, what made the difference for you, do you think? Is there one thing? Was it about, was it a person? Was it an approach? What's made the most difference to you, do you think?
The difference of me was basically a friend of mine who worked in the sector, i.e. Bernardo's. He realised and said to me, "You've got the strength to beat this." And also combined with that, I have 2 children,
right,
which impacted my life and do impact my life greatly. And the penny dropped, basically, that either I'm going to let my situation and the combination of things that exist externally beat me, or I'm going to beat it from the inside out.
Yeah.
I think there's a point in everybody's experience that they do have this moment that, face reality. Am I going to continue this way, or am I going to get myself out of this circle of events? And for me, the contributing factors were the 2 elements of the chat that, you have people come into your life that you don't really see again, though we're still friends, but my children were the overriding factor. And my actual strength that I didn't know I possessed, really, I would say, ultimately, to actually move from where I was to where I am or now.
Yeah. And do you think
not to let it define me, sorry.
No, I was going to say, I think that is that why we think that peer support can make such a difference? Because you have that lived experience that you can share with other people that helps them find the strength in them as well.
Well, yes, because obviously I've worn the T-shirt, I've been through the experiences, and I have survived. And if I've survived, I believe that, hopefully other people can take my lessons that I'm able to implore onto them to survive also, because somewhere, somehow, we have a strength from within. But obviously, it's always helpful if there's somebody who has lived or is in a similar, has been where you've been, to actually relate to you, because sometimes people don't relate to people, and it doesn't really make any difference, because what they say, well, what do you know? You've not lived the way I've lived, you've not experienced what I've experienced. But when people do, it doesn't work in all cases. Some people tend to sometimes make a choice to continue, where they're at. But I find that, I'll say maybe 7 times out of 10, or you can make a difference just by, giving people your experience and letting them know that you can, make it to the other side.
Yeah, thank you for that. That's really helpful. Daniel, I think you have another question, don't you?
Yes, thank you both.
Is
Accepting
it
that
for me, Leroy? Is it
I think it could be for both.
for both? Oh, who do you want to start with?
No,
I think both
Start with me or?
accepting that co-production is a feature of the VCS approach. Are there any examples of user-led interventions that work? Did you both hear that one?
is that the co-production question?
Yes.
Yes. So yes, I could give a few examples of things that work. So we house a group called Expert Link. They're very soon going to become a charity in their own right, and they are a national network of people that experience of homelessness. So they're one user-led organisation that I can definitely recommend that works really well. One by David Ford, who works in our office at the moment, but again soon about to fledge the nest and become their own charity. We also have Homeless Link, an expert panel. Leroy is a member of that expert panel who meet quarterly, and we use them as a sounding board for policy discussions and focus groups and all sorts of things. And we get a lot of insight from them. Example being when we did our supported housing consultation response, we were very happy to use expert panels views because they gave us some really clear examples of, what's needed from their point of view. Other things I could share would be there's Pathways, another charity who deal with health and homelessness, and they have experts by experience that they work with too. They also have a great panel at their conference every year, people who stand up and say what's happened to them and how they've got through, as Leroy was just saying, how they got through their challenges and came out the other side. Groundswell mentioned earlier, they have their peer support and peer advocacy network as well, which is very powerful. And also Making Every Adult Matter, again, that's hosted by Homeless Inc. as well, and we've got local involvement networks around the country that do co-production with people with experience. So there's a range of different things that are working. I think that again, for health partners, if you're not sure where to start with co-production, talk to your local homelessness organisations, talk to Homeless Links, partnership managers in your region, and we can help you to make those connections and links with people that can reach others who may not have access to the conversation that we want them to be in, and do that co-production piece really well.
Thank you, Caroline. Do put your hands up if you would like to be unmuted and ask your question directly.
Hi, it's Kathy here. Can I ask a question?
Yes, please do.
Yeah, it's for both of you really. Leroy, you talked very helpfully about wellbeing hubs. So I suppose my question is, what is being done, or what can we do to share what works and feed that into local level planning from what we know works around the country? And the second part is, what can we do, or what can be done, or what is being done about getting information out to people who most benefit from things like wellbeing hubs, etc. How's that information? What's the best way of getting information out, sharing with the homeless community and rough sleepers?
Okay, I'm going to hand over to Leroy to answer that question. I'll tell the question to him because he can't hear me, so he can't hear you, Kathy. So I'll repeat the question to him while I'm handing over. Bear with me a moment.
Yeah, hi there. I believe I'm speaking to
Kathy.
Kathy. Hi, Kathy. Can you hear me, Kathy?
I can, Leroy.
Thank you. Yeah, well, I believe in joined up thinking and joined up conversation. And that I think is missing at times, where obviously because due to data protection, people keep their own information sort of, to themselves. But I believe that you need, for these wellbeing hubs to work, is you've got to have collated and joined up information sharing, so that those that are, obviously come into the hubs and are part of these hubs can receive the proper assessment and intervention. because I think it's been lacking over a long-term period where people are not monitored, people are not tracked, for want of a bit of a word, to find out how they can be helped. You see, you can talk to people or you can talk at them. And I believe talking to people is key. I found that in my experience, and speaking to them as an individual. And well-being is what it says, really. You're actually looking for the whole person, not just about how they are at the present time, but what actually causes or are the triggers for them to become unwell. And then you can use that as a sort of a device to look at the ways to help them, maintain their overall and better well-being in the long term.
Yeah, thank you, Leroy.
Thank
Was
you.
there anything more, Kathy, or have I
No,
answered?
that was really good, Leroy. I was quite interested in about, because you talked really helpfully about wellbeing hubs, and I was interested in how we can get information, or how Homeless Link and others get information out to local planning forums, etc., about what is working around the country, but also about, which you very helpfully talked about, is about how we engage more to let people know that health wellbeing hubs and other accessible options for them exist, because it can be quite difficult, obviously, with the community and being able to get the services that support them.
Yeah, it's very, very essential for long-term recovery, which I'm a big, obviously, advocate of. Thanks, Kathy. Is that okay?
Thanks a lot, Leroy. Thanks for that.
All right. Thank you.
Thank you, Leroy and Kathy. So I think we have a question from Rebecca now. I thought I saw a hand up, but it's gone down, so maybe I can just ask the question. You mentioned the cycle about going through A&E and the acute ward. Do you have any examples about services and ideas that could work or have worked?
Not one for Leroy. So this question, Leroy, about the cycle of going to A&E and back onto the street. I think for my part, and I'll hand off Leroy for his part in a minute, but I think from my experience and from what I've seen, talking to colleagues who've worked in those sorts of hospital environments with homeless people who have been homelessness, who are on the wards, is there's also a challenge with delayed discharge and a challenge of pressure on beds. So people are often discharged onto the streets when they appear to be well enough. Interventions that can help probably is challenging because of the lack of resources we've got in hospitals themselves. But I think what we need to do more is work closely with hospital social workers that are there working with people who are homeless, work more closely with them and try to do a bit more structured discharge planning for people. So when they leave the hospital ward, they actually have somewhere to go or someone to go to. I think that there's that challenge about how we can ensure the services are more linked within the hospital itself. Leroy will want to add to that, so I'm going to pass over to Leroy.
Yes, I think a key factor in this is the care coordinators, which I've been working with or have worked with in the past. And I've recently done some visits to supported accommodation units where we were finding out what the feelings were of the people that were actually in these accommodation units, what they felt was working, what they felt wasn't working. And obviously, you'd find this cycle, as I mentioned before, A&E, acute wards, and going back and forth. But what was happening is that the care coordinators, which are a key part of this, the information wasn't being acted upon, or you had someone who was prone to go through A&E and obviously go to the acute ward and go back on the street. It wasn't being actually, as I say, picked up on, and it was just a reoccurring cycle. Now, obviously, there was information sharing, and there was some way that the person wasn't discharged, or if there were family members that could be brought into play, that could provide a more secure setting for people, because obviously sometimes it's just a reoccurring theme with people that they get the help they need, or they want some respite, they go to A&E, they go to the acute ward, then they're back on the street again. Now, somewhere obviously between there, the rot has got to be sort of stopped, and I think care coordinators and care coordination is a big part of this, that we can maybe sit down and find out what are the triggers, why are these individuals ending up on the streets on a regular basis, and then looking at that from an overall view and see if we can address, because there can be contributing factors to people just going out on the streets, continuously. And I think that's something that, it's subjective to each individual. So it's not a one size fits all. So, sometimes it's the areas that they're going back into the same areas where they were before. I don't know how we actually will address that, but that's something that really is a concern, because I have met people I've dealt with or been around for 5 to 10 years, and they don't seem to have moved on. It seems to be that cycle, going on the streets again, coming back out, going back. It's just a vicious circle. So somewhere, some joined up thinking and some working together needs to come together, a common theme to stop, this hemorrhaging, which I believe, to stop it occurring continuously. Thank you. I hope I answered your question there.
Thank you, Leroy.
Okay.
Okay, so I think we don't seem to have any more questions and no more hands up. So I think we can bring the session to a close unless anyone has any last minute questions. If you do think of anything after the webinar, please do send us an email and we'll be happy to pass that on to Caroline. Oh, I have seen a hand up, sorry. Let's just stop that and go to Neil, who would like to ask a question. Neil, you have been unmuted.
Not a question, just a quick comment that I found Leroy's description of what peer support is extremely helpful. It's just a comment I wanted to say, so thank you.
I will
Thank you,
definitely
Neil.
pass that on to Leroy. Yes, your description has been very helpful. Thank you for that.
Thanks, Neil.
Pleasure.
So if you do have any more questions or comments, then please do email them to us. Oh, one more question. As I start to wrap up, what is the referral link in place to help local authorities pick up cases on time and intervene? So
Sorry, can you repeat the question, please? I didn't quite hear the last part of that.
Sorry, what is the referral link in place to help local authorities pick up cases on time and intervene?
Right, okay. So the mechanism is the Homelessness Reduction Act. So there's duty to refer in that act, so that health, amongst other public bodies, have duty to refer someone that they think is a risk of homelessness to relevant service. So that's the mechanism that public services ought to be using. I'm hearing that the front line has not quite heard about the HRA everywhere yet. So there's work going on. I know Department of Health has done extensive guidance for frontline to use. So it's really important that the health partners are using that guidance, so they can actually then work with their local authority partners in a way that can help prevent and pick up homelessness before it starts. So basically, the Act has allowed the time that a person is at risk of homelessness to be doubled to 56 days. So that gives more time for advice, information, support, and duty to refer to be enacted, so the person can be stopped from becoming homeless. So that's a mechanism everyone should be using.
Thanks, Caroline. And I think to end this session, would I just share a comment from Shelley, who said thanks to you both for the very insightful, I've said for the insightful meeting. So thank you both to Caroline and Leroy, and thank you everyone for attending. As I said earlier, we will make the recording available in a few days, so do keep a lookout for that, and you can share that with your colleagues, of course. Thanks everyone, and bye-bye.
Thank you.